Welcome, everyone, and thank you for joining Night 2 of the deVeber Institute's Emergency Lecture Series on Bill C-7 and palliative care. We are honored to have four remarkable speakers with us tonight. My name is Zoe Stewart-Bedard, and I'm the Executive Assistant to the Board of the deVeber. I will review some of the particulars about the lecture before we get started. First off, to best view the lecture tonight, be sure to adjust your Zoom monitor to speaker view, and you can do so in the top right-hand corner of your screen. Secondly, there will be a question period at the end of the lecture tonight. Please submit questions during the presentations so we can begin right away. We will address as many questions as possible, and any that we do not have time for, we will try our best to answer and send replies out to all in attendance tonight. To submit a question, please use the Q&A box at the bottom of your screen. This entire lecture is being recorded and will be available on our website tomorrow. In addition, you can also view last night's complete lecture on our website already. And our website is www.deveber.org. deVeber is spelled D-E-V-E-B-E-R. I will send out an email to everyone in attendance tonight also when that video is made available tomorrow to give everyone a heads up about it. We will begin our lecture in just a moment.
Good evening. I'm Martha Crean, and I'm the president of the board of the deVeber Institute. Thank you for your presence tonight. For over 40 years, the deVeber Institute for Bioethics and Social Research has been asking important questions, bioethical human life issue questions, and seeking answers based on the evidence of research and experience. Our name, deVeber, honors Dr. Barry deVeber, the late pediatric oncologist who was a pioneer in Canadian palliative care for children. 1 year ago today, it's likely that not one of us could have foreseen the remarkable redirection in our lives due to COVID-19. Extraordinary social solidarity has been called for to meet this pandemic, to protect human life, particularly the elderly and the most vulnerable. At the same time, we have been called to give special appreciation and respect to the frontline workers who have really gone above and beyond all expectations of service, and especially to all those involved in healthcare. Yet, in the midst of this mobilization to protect human life is the much less discussed but increasing practice of assisted suicide, legalized in Canada as MAID, medical assistance in dying, 4 years ago, actually 4.5 years ago. Now, at this moment, Parliament and the Senate are hastening to broaden medically assisted death through Bill C-7. What are the implications for all of us as patients now or in the future, for our families, and for all those involved in healthcare? Last night, and again tonight, we have the incredible benefit of listening to learn from 7 frontline medical, legal, and bioethical experts. We're grateful to them for making possible this emergency lecture on Bill C-7 and palliative care. Tonight we have 4 speakers. The first speaker is Dr. Sephora Tang, who is a psychiatrist in Ottawa, Ontario. She's going to give us a brief intro to where we're at with the bill, and then focus on the need to improve assisted living prior to assisted death. Dr. Sephora Tang, thank you.
Good evening. Thank you to the deVeber Institute for putting together this lecture series and for inviting me to speak. And I just want to make sure that I actually am unmuted. Okay, great. I'm Dr. Sephora Tang, an outpatient psychiatrist working at a large academic acute care hospital in Ottawa, Ontario. The views that I present tonight are my own and do not represent the institution for which I work. Tonight, I am hoping to provide my perspectives as a clinical psychiatrist in the debate over Bill C-7, which opens the door for medical assistance in dying, also known as MAID, to those who are not dying. Before I begin, I have been asked to provide a cursory overview of MAID legislation in Canada, just to recap the events of the last 5 years. Then I will review some of the concerns raised by including specifically mental illness in the MAID legislation. I hope to share some practical implications to the practice and delivery of psychiatric care that this would entail. And then I will highlight some of the inequity in access to services that I see daily in my patient population. Finally, I will conclude with some considerations as to how we can respond to this legislation in a way that will help to build a safer and more just society for all. The next couple of minutes as I provide a summary of the legislative process thus far will be familiar to those who heard Dr. Leonie Herx present last evening, as this will be a recap of what she shared. So feel free to tune out for the next couple of minutes if you heard her, otherwise continue listening. So the 2015 Carter versus Canada case led the Supreme Court of Canada to strike down the criminal prohibition on homicide and assisting in suicide for the purposes of MAID, giving Parliament 18 months to develop new legislation. This resulted in Bill C-14, the Medical Assistance in Dying Act, that was enacted on June 17, 2016. It stated that physicians or nurse practitioners may provide euthanasia and assisted suicide, otherwise known as MAID. The specific eligibility criteria included that patients eligible for publicly funded health services in Canada would be able to access it. They had to be at least 18 years of age and capable of making decisions regarding their health. They needed to have a grievous and irremediable medical condition, including an illness, disease, or disability, and the requirement that their death needed to be reasonably foreseeable. Their request also needed to be voluntary, and they needed to be able to provide informed consent. They delineated a number of standard safeguards, including a mandatory 10-day reflection period, which would allow patients requesting MAID to change their mind. And they needed to have 2 independent witnesses for the request, and then 2 independent assessors. The patient requesting MAID needed to have capacity at the time of the request and at the time of the procedure. Note that under Bill C-14, medical assistance in dying was made a healthcare right under the Canada Health Act and thereby had to be publicly funded and accessible. Importantly, no similar right exists to access palliative care or other supports such as disability or home care. Then in 2019, a court challenge at the Quebec lower court involving 2 individuals, Truchon, who suffered from cerebral palsy, and Gladu, who suffered from post-polio syndrome, who wanted a right to MAID but were not dying. The judge ruled that the reasonably foreseeable death requirement for medical assistance in dying was unconstitutional. Despite an outcry from over 90 disability rights organizations and hundreds of concerned doctors, the government did not appeal this lower court ruling. This is very unusual in that a government would allow a lower court ruling from one province to dictate changes to federal legislation. Now, in 2020 and 2021 with Bill C-7, this was the government's response to the Truchon ruling, which removes the criterion that death needs to be reasonably foreseeable. Besides that, it goes well beyond what the Truchon case had ruled by removing the safeguards that were initially felt to be important to protect vulnerable persons under Bill C-14. Bill C-7 was tabled in Parliament in February 2020, but due to the prorogation of Parliament was reintroduced in October 2020. Bill C-7 passed 3rd reading in the House of Commons in November and was passed in the Senate with a number of additional amendments. The government responded this week to the Senate's amendments by accepting some of the changes, including accepting eligibility for mental illness as a sole diagnosis criteria, through a sunset clause of 24 months. Originally, the Senate had proposed 18 months. The debate started yesterday before voting is to come in the coming days. So here are some of the changes to the MAID regime under this new bill C-7. It removes the requirement for death being reasonably foreseeable. It does so by creating two tracks. So track 1 for those whose death is reasonably foreseeable, and those whose death is not reasonably foreseeable is known as track 2. Under track 1 for reasonably foreseeable death, there is the removal of existing safeguards, including the removal of the 10-day reflection period and removal of the requirement for final consent, meaning they don't need to be capable of consenting at the time of administering the MAID procedure. There was also a reduction in the number of witnesses from 2 to 1, and now this witness can also be a paid healthcare worker. Under track 2, for those whose death is not reasonably foreseeable, this would include any disability, chronic illness, and in 24 months, mental illness now as a sole diagnosis, whose capacities are irreversibly declined. Track 2 requires a 90-day assessment period. It requires one expert in the underlying illness to be involved. This does not mean direct involvement in approving for MAID. The person has been informed and offered other treatment options. But strikingly, there is no requirement for treatments to have been tried or to even ensure availability of treatment. This is the same provision as in track 1, but clearly the stakes are higher for a person who could recover with treatment and have decades of potential life to live, but are allowed to refuse the medical standard of care. As Dr. Leonie Herx indicated last night, this will make Canada the only country in the world to make MAID available as a first-line therapeutic treatment. So now that was a summary from last night. Now, this has all occurred at a pace that has not even respected the parliamentary process when Bill C-14 was passed in 2016. Canadians were promised that a parliamentary review was to take place at the end of 5 years before further expansion to the 3 groups under study for psychological illness alone, advanced consent, and mature minors. This parliamentary review has not yet occurred, and already we are expanding the legislation. Now, turning our attention to specifically including mental illness in this legislation. When Bill C-7 was introduced last year, it explicitly excluded mental illness as a sole eligibility criterion, presumably because there was a recognition at the time that there were fundamental differences between illnesses of a medical nature, such as cancer, that have a more predictable trajectory, and illnesses pertaining to mental disorders, such as a depression whose trajectory can be variable. It is also difficult to differentiate between those who are experiencing suicidal thoughts as a result of symptoms of mental illness and those who are requesting to die for a mental illness. This is a point that differentiates mental illnesses from physical illnesses, which do not have inherent within their diagnostic criteria suicidal thoughts as a symptom of illness. Therefore, it would be prudent to treat eligibility criteria for MAID for mental illnesses differently from physical illnesses. Over the past several months, mental health experts testified at Senate hearings and warned of the dangers of including mental illness as a sole eligibility criterion for patients who are not dying. Their warnings were not heeded, and the federal government accepted the Sunset Clause amendment to include mental illness as a sole diagnosis criteria in 24 months. The lack of prudence demonstrated by our legislating bodies in recommending such an amendment without adequate evidence or data on which to substantiate their policymaking is bewildering. Agreeing to implement a sunset clause of 24 months before enacting a MAID regime for mental illness is akin to setting a train in motion without knowing if there will be still tracks on the ground in 24 kilometers. Or, putting it another way, it would be like allowing your citizens to jump off a cliff and trusting that while in free fall, the government will be able to put in place something soft and fluffy at the bottom of the cliff to catch those whose lives we consider worth saving, while allowing those whom doctors have deemed eligible for death to not be saved. Before proceeding, I just want to highlight the question of the irremediability criterion that is required in the bill to permit a patient to be eligible for death services. In order for a person to qualify for MAID currently, the condition from which they are suffering must be deemed irremediable. Leading academics, including the Council of Canadian Academies and the Centre for Addictions and Mental Health, have stated that there is currently no evidence that irremediability can be predicted in mental illness. What this means is that under this new law for mental illness, some people who are suicidal because of symptoms of a mental illness will die when they would have otherwise recovered. There is no way of being able to predict this in advance. For a country who abandoned the practice of capital punishment because it was deemed that one wrongful death was one death too many, it is shocking that we in year 2021 would be so reckless when legislating upon the deaths of mentally ill patients. We as a country are far from being able to offer the level of timely access to care that would be needed to save the lives of those who most need it. Of note, during the 90-day assessment period, patients only need to be offered information for potentially life-saving treatments, such as medications, psychotherapy, skills building, vocational rehab, supportive living, etc., etc. It fails to consider the fact that the waiting time currently in this country to access mental health services can far exceed 90 days in certain regions. This does not even take into account the long period of time that it can take for illnesses to recover with appropriate treatment. For some, the slow process can take years. What I find most extraordinary in this bill is the fact that nowhere in the bill is there a requirement for medically administered death to be an option of last resort, and that patients do not even need to be required to undergo treatment of any kind before receiving MAID if that treatment is deemed unacceptable to the patient. This is unprecedented, even in jurisdictions where euthanasia is legal for mental illness. In the Netherlands, for example, there's a requirement that both the patient and the physician come to the conclusion that there is no reasonable alternative. If patients may access MAID, despite refusing available standards of care, what will be the test for irremediability? It should also be acknowledged that the competence of physicians, even amongst psychiatrists, are not equivalent, some being more familiar than others in managing seemingly treatment-resistant cases. The consequence is that a less skilled physician may deem a patient to be irremediable. What shall become of the patient who is led to believe there is no further effective treatment options, and the availability of a competent second psychiatric opinion is lacking due to scarcity of resources? From my own experience, a suicidal patient came in to see me for a consultation, her last resort after years of therapy. She expressed a desire to receive MAID if it were available, yet the law had not changed at that time to allow for this. However, upon further evaluation, despite 20 years of therapy, including lengthy psychiatric hospitalizations, it was discovered that she had not been offered the basic medication management for her diagnosis. After letting her know there were actually quite a few options yet to be tried, she agreed to not end her life just yet and allowed another chance for treatment. Patients like this case, who because of lack of proper care and expertise, are left without hope that things will get better and may choose an assisted death if it is readily available for mental illness. This patient was given some hope for a better future, and because of that, was given more time to live against the ever-looming presence of death. The more readily accessible euthanasia becomes for those who want it, the more patients will drift towards wanting it. Although an assisted death was a welcome option for my patient, inflicting death on request would have been a fatal failure of our healthcare system to provide proper diagnosis and management to a vulnerable individual. For me as a psychiatrist, it would be a great perversion of the nature of psychiatric care within the medical profession to facilitate the suicide of patients when we are skilled at providing them hope with treatment, to enable them to walk out of the darkness that has engulfed them. It is the antithesis of good psychiatric care to terminate the life of patients at the peak of their suffering before they are given the opportunity to seek relief. And it is a disservice to family members whose last memory of their loved one will be one who is suffering and who will never be able to have a chance to recover their meaning or purpose in life because their life was terminated too soon for that to happen. This begs the question as to why we would want psychiatrists to be involved in this practice at all. When we take our loved ones to the hospital because we fear they are going to harm themselves due to a derangement in their thought process, or because they are so depressed that they are suicidal, the last thing we would want is for the psychiatrist to offer them an assisted suicide, the very outcome we are trying to prevent. To take this even further, the Senate has suggested an amendment to make it a duty for physicians to inform their patients of all potential options, including an assisted death. Cases in Canada have demonstrated that family members have very little influence over the doctors who determine whether or not a patient is eligible for MAID, as it is deemed to be a purely individual decision, and families really don't have much of a say in the matter. Do we really want to live in a country where we need to fear bringing our loved ones to hospital to receive care because we are worried that their doctor will not only suggest an assisted suicide as a reasonable treatment option, but as well as make all the necessary arrangements to ensure that it is completed in a fail-proof method? Suicide prevention strategies entail restricting access to lethal means. Permitting MAID for mental illness does exactly the opposite. By following through on this bill, we risk co-opting a mental health system intended to help prevent suicides into facilitating suicide for those whom our health and social systems have failed. And there are several points of failure in our mental health system to date. Psychosocial stressors that can be difficult to predict often precipitate suicidal ideations. This COVID-19 pandemic has unfortunately highlighted several areas of stress that I see daily in practice only worsen with the consequences of trying to contain an infectious virus. All the stressors that people can potentially experience day to day has been exacerbated to a larger scale during this pandemic. This includes financial stressors, social isolation, job insecurity, inability to access accessible housing in a timely manner, lack of personal support workers to maintain the daily functions of life, lack of affordable residential addictions treatments, lack of mental health treatments such as psychotherapy that is affordable, etc. In Ontario, psychiatric services are covered by the Ontario Health Insurance Plan, but psychotherapies from counselors and psychologists are not. For my patients who are supported on welfare, who have no insurance, potentially life-saving treatments are not affordable. Some of my patients, the working poor, who have neither social assistance nor insurance, need to decide whether they will spend their check on groceries or the medications they know could help them to feel better, but cannot afford. Furthermore, the services that the provincial government provides are often reserved for the walking well. Many of my patients are only able to access one-time psychiatric consultations before being discharged back to the care of their family physicians to manage. My sickest patients who are suicidal and actually need psychotherapy are turned away from community resources because they had attempted suicide in the last 6 months and therefore are deemed too high risk for community therapies. I can understand that, but then where are these suicidal patients supposed to get help? I work in the mental health profession, and even I am at a loss. We don't have the numbers of psychiatrists to be able to sustain the demand and need for psychiatric care, and our patients are suffering as a result. At the hospital where I work, we have had to close psychiatric beds because we are so short-staffed as psychiatrists. The wait times to get specialized support services are exorbitant. I've been told for some of my patients requiring care that patients in Ontario requiring intensive residential support for traumatic brain injuries can wait for up to 10 to 15 years. What are they supposed to do in the meantime? Low-cost housing is also deplorably scarce. My patients who are in wheelchairs have to wait literally years, 7 or 8 years, to get an apartment that is fitted to their height. Imagine not being able to do your dishes in the sink or cook for yourself because the counter space is built too high. Another of my patients described the blood-stained walls and bed-bug-infested low rental housing that was offered to him after discharge from hospital. For someone who has a history of trauma, the sight was enough to retrigger a spiral back into addictions and suicidal thoughts. I don't think able-bodied people realize the difficulties that people in the disabled communities face, especially when they are living in poverty and struggling every day just to survive. These stresses and challenges can seem monumental, especially when coupled with an unmanaged mental illness and inability to access care. It is against this stark backdrop that our federal government is legislating increased access to MAID. As I recently wrote in the Ottawa Citizen with Dylan, without the necessary supports in place to parallel a permissive MAID regime, individuals are left with the prospect of choosing between an assisted death or continuing the uphill struggle of living with inadequate supports. To place an individual in such a predicament is cruel and fundamentally unjust. When discussing this debate, we need to remember the needs of these people who for far too long have had their needs sidelined and unaddressed. When I am requesting that the government put a halt to MAID expansion for mental illness, it is because I have before my eyes the faces of my patients who I know would choose MAID, not because they can't recover from their mental illness if they were given the time, but because their life circumstances of poverty, addictions, and social isolation has made it unbearable to live. I ask again, is this the kind of society that we wish to build? And should we not be doing more to support the living to live rather than facilitating suicides? I would encourage each of you listening here tonight to ask yourself, what role can you play to bettering the lives of our vulnerable members of society? This could include speaking to people in the disability communities to understand what their needs are, familiarizing yourself with disability organizations, raising the issues of inaccessible care with your members of provincial parliament, and holding government accountable to providing care that is sorely lacking. This means starting work towards creating space in society where we can say that the lives of all people matter, and to build infrastructure that leads to supporting all lives, not ending them. People with mental and physical illnesses and disabilities deserve safe spaces where they can go for life-affirming care without worrying that the doctor assigned to treat them might suggest a lethal injection unsolicited in a time of vulnerability. Advocate for safe spaces for your care and the right to have a choice in receiving care from a doctor who you can trust to value your life at all stages of your life without exception. To attain this, we need to also protect the rights of medical professionals and institutions to practice according to their conscience in declining to participate in facilitating life-ending processes against their will. Without this freedom to practice medicine with ethical integrity, our society will have killed the heart of medicine, and in doing so, the lives of our people as well. I will leave you with these words by Mark Hennick, a mental health patient and advocate with the Mental Health Association, who made this poignant statement to physician attendees at the 2017 Canadian Psychiatric Association conference, whom I paraphrase. Quote, "If I had died at the time that I wanted to, at all the times that I wanted to, I would never have been given the time to figure out that I didn't want to." Patients turn to their doctors for help and for hope. If you physicians don't fight back to fight for our lives, we won't be alive today. Patients need to know that there are people they can turn to who will help them and fight for them, end quote. Against the bleak backdrop of Bill C-7, we have an opportunity now to advocate harder for safe and equitable access to care for all. Let's not fail in doing what we can and what is necessary to build a safer, more inclusive, and just society. Thank you for your attention.
Now, thank you very much, Dr. Sephora Tang. That was a very powerful call to consideration, to action, to change. And you have given us a very full picture of the work that you are doing and the reasons that the Senate needs to reconsider and Parliament needs to reconsider based on your insights into the psychiatric elements involved in making good patient care and not short-end choices. Thank you very much, Dr. Sephora Tang, tonight. Our second speaker is also a doctor, Dr. Jaro Kotalik, who is a professor at the Northern Ontario School of Medicine with Lakehead University. He's going to be speaking tonight about the need to improve monitoring and reporting of MAID statistics. Thank you very much for speaking tonight, Dr. Jaro Kotalik.
Well, thank you very much for being invited. I probably should add, as Dr. Tang did, that I'm not speaking on behalf of the medical school or other organizations I am affiliated with. I'm speaking as a bioethicist who is often being asked to examine the ethical aspects of particular healthcare programs, or ethical quality, if you wish. And because of that, I became interested in ethical issues concerning MAID. There are many, but today I will speak only about one of those issues, which is very relevant to the current discussion on Bill C-7. And this is the lack of accountability and lack of transparency. These are characteristics which were promised on the paper, but failed to deliver. In order to prove my point, I have to go back again to the beginning of this the history. In Canada, it is still indictable offense to counsel a person to die by suicide or aid a person to die by suicide. No person is entitled to consent to have death inflicted on them, and such consent does not affect the criminal responsibility of any person who inflicted death. These were the provisions which were inserted into criminal code when it was created in 1892, and they are still valid. Only thing is the change instituted in 2016, at which time, as already Dr. Tang explained, that the Supreme Court determined that the absolute prohibition is in conflict with the Charter of Rights and Freedoms, and as a result, sketched certain conditions under which the prohibition need to be invalidated. The court was persuaded, and I will quote, that the risks of physician-assisted death can be identified and can be minimized through a carefully designed system that imposes strict limits that are scrupulously monitored and enforced. Well, based on instructions of the Supreme Court, the Parliament approved Bill C-14, which made it possible to provide medical assistance in dying in spite of the general prohibition of homicide, which I mentioned above. It was implemented with three basic conditions. One, that assisted dying will be provided by medical practitioner or nurse practitioner. Two, that the person will applying and receiving MAID will meet 5 eligibility criteria. And three, that the MAID provider will follow 9 procedural safeguards. The law states, and I quote, robust safeguards reflecting the irrevocable nature of ending life are essential to prevent errors and abuse in the provision of medical assistance in dying, unquote. And then also declares that vulnerable persons must be protected from being induced in the moment of weakness to end their life. The law states also that MAID provider who knowingly fails to comply with the safeguards and may receive a jail sentence for up to 5 years. This 2016 law also states that the Minister of Health must make regulations for collection, analysis, and publications of information about MAID cases, as they must be reported to the minister by all MAID providers. The MAID law also specified a punishment of jail time for those who would contravene those regulations, destroy or forge documents, and so on. So far, so good. So it's, I would think that reading the law even now, you may get the impression that there is a serious effort to balance the access to medical care for a mature, competent, well-informed persons who are at the end of life, while at the same time protecting the life of all other Canadians. But the problem with the implementation emerged right away. Canadians started to receive MAID within days of the approval of the law, but no regulations were in place to say what should be reported and to whom should be reported right away. And during this void, all provincial governments scrambled to develop their own often rudimentary report forms for MAID providers. And then later government came up with the interim monitoring reports, which they admitted are incomplete. So it took 2 years and 4 months before the federal monitoring regulations were issued, and then another 1.5 years before the first federal report of MAID was released, which presented the results of this collection of the data. In the meantime, of course, many people across Canada became especially concerned about the state of affairs. And I will quote from a paper in World Medical Association of a group of Canadian physicians that the failure of adequate oversight, review, and prosecution for non-compliance with these legislations are a serious problem for the program. Now, those of us who hoped that the first annual report of the federal government could relieve our concern were very disappointed. The report, which came in July of last year, was set up to explicitly provide a societal perspective. And it did not attempt to systematically analyze whether every made cases was reported or not, or whether every case fulfilled the legal obligation as concerned the eligibility criteria and safeguards. The explanation offered was that, well, these are matters of criminal law, and enforcement of the criminal law is the responsibility of the provincial and territorial governments. What these provincial and territorial governments did about this matter, well, only Ontario and Quebec released some information about their examination of made reports from their provinces. But there is no information in the public domain in the remaining 11 jurisdictions in Canada. To summarize, it means that of the 13,000 deaths reported in the first federal report last year, we have some evidence that these reports produced by maid providers were scrutinized in only 3,000 deaths. So our last hope that the accountability and transparency of the MAID program can be addressed was the promise, which was in Bill C-14, that 5 years after implementation of that law, there will be a parliamentary review started. And that then was supposed to start in June 2020. But this legal obligation was ignored. And instead, we have now the draft of Bill C-7. And Dr. Tang, I think, already explained what is the essence of this new legislation. So, one, removal of several safeguards, which were thought to be absolutely crucial in the year 2016. And yet, we're doing at the time, we actually don't know if those safeguards were followed in the past 5 years. And no justification was really provided in Bill C-7 for the particular removal. And the second, the Bill C-7, as you heard, is extending criteria of eligibility outside of the situation where natural death is reasonably foreseeable. Yet, we don't know how often these original criteria has been followed to make these MAID intervention to comply with the criminal law. So, do we have, as court asked, carefully designed system that imposes strict limits that are scrupulously monitored and enforced? I don't think so. I suggest that we have to ask also, given the situation and the failure of monitoring and reporting, is this the right time to move ahead with the overhaul of the whole program as Bill C-7 is proposing? So these are my concerns, and I will be very interested in your questions and maybe comments from my other panel members. Thank you.
Thank you very much, Dr. Jaro Kotalik. You've really revealed the hollowness of any claim that there is reliable accuracy in reporting that we may look to since this law was changed. Thank you very much for revealing how this has not been accomplished as was promised originally, and yet we're moving forward. We appreciate that. And speaking of questions that you're welcoming, may I remind people today that we are inviting you to type your questions in and submit them And we will answer as many questions as we can at the end of the fourth speaker. Thank you. The third speaker today is our own Bob Parke, who is a bioethicist and also the vice president of the deVeber Institute for Bioethics and Social Research. Bob is going to be speaking tonight about the philosophy of palliative care. Thank you very much. And also, indeed, I believe, Bob, you're going to be talking about the need for early engagement. So Bob Parke, we welcome you tonight. Thank you.
Good evening. I hope you can hear me well. And I hope you can also see my screen. I'm just getting things up and running here. So hopefully you don't have any problems with technology, because I'm still a little bit new to this. So I ask for your indulgence. One of the things I wanted to do is just to share with you, there's this wonderful book, and I hope you can see it on the side of my first slide. It's called It's Not That Simple. And it was one of the books that was published by the deVeber Institute with some amazing contributors. And if you haven't read it, I would put a plug in to encourage you to pick up the book and go through it, because there's some wonderful information there that can be very helpful. Over the next few minutes that I have, what I wanted to do is, to go over the foundations of palliative care, a little bit about philosophy and practice of palliative care, and then some desired outcomes. And I too am going to build on what was said last night by the other physicians in our group, and hopefully I have some good answers to some of the questions that you may have when we come to a conclusion. So the first thing I wanted to say and share with you is that, and I'm quite proud of the fact that the person who created the term palliative care is Dr. Belformant, who is a Canadian who, as you can see from the cardigan he's wearing, was from Queen's University, but he is actually more associated with McGill University. And those who are involved in palliative care would know that every 2 years, I believe, there's an amazing conference that takes place in Montreal, centered around the foundations of his work. And one of the things that he had a vision of was the vision of whole person care. And we'll come back to that in a few minutes. And the other person that I have, how do I say, somebody I admire very much, and I've oftentimes quoted her. If you've ever seen me present in terms of palliative care before, you know that I put this quote of hers in my presentations. You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but to live until you die. Dame Cicely Sanders, by the way, was the founder of the modern hospice movement. Interesting is some of our colleagues had said already about we need assisted living. And if we're going to help you live until you die, we do need that assisted living. One of the things that both Dr. Belformant and Dame Cicely Sanders had in common was the belief in the concept of total pain. And in this quote, also from Dame Cicely Sanders, suffering may be related to the pathophysiology of a disease, but it is always modified by the psychosocial, spiritual aspects of suffering. And I want to just, and that's, by the way, is in the lower right-hand corner, you will see a picture of St. Christopher's Hospice, which she founded. And Dr. Belformant went there and had to roll up his sleeves and learn about the patients she was working with. And she didn't want him flying in for a weekend. I think he had to go in there for at least a week and learn from the experience of that particular hospice. But both of them had this very important notion of total pain, and that we need to address total pain in palliative care. And I think anybody who's educated in healthcare, educated in palliative care in particular, will know about total pain. And of course, it makes sense when you look at this simple graphic that, of course, we need to look at what are the physical issues that the person is dealing with, what are the social issues, what are the psychological, and what are the spiritual. And if some of those domains like social or spiritual or psychological are heavily stressed at any given point in time, that too can impact on the physical. And I think of a situation like a young man who had a cancer diagnosis. It was terminal, and he was the breadwinner for his family. And he was very worried about how would he pay the bills for his family. He had medical coverage through his workplace insurance, but now that he's not able to work, How would he provide for medications, not only for himself, but also for his family? And of course, this alone was causing him a lot of stress around how will the bills get paid. Now, when we think about palliative care, we think about palliative care as being a team effort. And certainly, in this particular situation, a referral to a social worker would be very important, because that social worker could sit down with this family, with the person, and look at what are the challenges they have, what are the resources they have, and then look at what might they be offered in terms of support, so that the medications can be covered, and so that bills can be paid, and hopefully rent or mortgage can at least be covered, and also to help to plan for the future when the parent was not there anymore, and who might be there to or how supports might be available to them. And you can imagine, if the social worker is present in the addressing total pain, some of the physical stresses that this person would have would be diminished, because you could see that they would be very tensed and stressed, thinking about how am I going to pay my bills. But if that stress is removed, then even the physical side of that person's situation can be modified. By the way, last night I was I enjoyed hearing the physician speak, and Dr. Bouchard, I think, put a note about recreational therapists. And I added a note in the chat about the importance of recreational therapy, and how recreational therapists, through their engagement with our patients, can help, for example, with distracting from pain, distracting from the stresses that the person may be experiencing, through artwork and through other activities that can be very helpful. And in the one situation that I was quite familiar, the patient felt a loss of meaning and purpose, actually due to a stroke. And her meaning and purpose in life was largely around the fact that she loved to crochet. And because of the stroke, she couldn't crochet anymore. And so she became depressed. Her affect was depressed. And we tried all different kinds of therapies and counselors, etc., but nobody had a breakthrough. But somebody, a brilliant person, asked for a recreational therapist to be involved in the care. And that person found a way for the crochet hook to be mounted on the bedside table. And that person was able to use her one hand and start crocheting again. And when she was using the one hand and seeing that she was able to create lines of yarn, she started to regain her affect in a more positive way. And that turned the situation around, where she became a rehab candidate. And from the rehab, admission to rehab, rehabilitation, she then was able to go home. And so a team member who we don't always think about, like a recreational therapist, made a big difference for this particular person. I will also say that dealing with the spiritual side of total pain is very important. You know, sometimes we may have formal religious affiliations that are important, traditions that we want to carry out when somebody is dying, but sometimes we may not have a formal side of a formal spirituality that we adhere to. And so we can work with people around telling their life histories, putting those together. And sometimes we may find that there are reconciliations that can be helpful. And how many times, even in our own lives, sometimes we've had fights with family members or fight with friends over silly things. And if we have an opportunity to seek reconciliation, we can be at peace. And so when we are able to address social, psychological, spiritual, then we can also help to modify the physical experience that the person is having, perhaps even having the need for fewer medications. Now, one of the things I wanted to share with you is, I've been doing work with Ontario Palliative Care Network, with Hospice Palliative Care Association of Canada. And one of the terms that we use now is palliative care is disease agnostic. And I'll share with you what I mean by that in just in this slide here. I hope I'm not moving too fast, because I know in some computers the transitions are not as good with Zoom. But in the first wave of palliative care, it was largely focused on cancer care. And we were doing good with that. And Dr. Belformant and Dame Cicely Sanders, for example, did some tremendous work with cancer care and palliative care. And then the second wave was the wave in which we saw people with HIV and AIDS. And if you look at here in the city of Toronto, a well-known hospice is Casey House. So they had the first wave with cancer, the second wave with HIV/AIDS, but now we're in this third wave, which we would call disease agnostic, because it's inclusive of all end-stage diseases. You know, sometimes we may be thinking, oh, palliative care is just for cancer care. No, palliative care can be for all end-stage diseases, like heart disease, like kidney disease, like dementia, like ALS, to name just a few. I mean, it's not uncommon for people to have a heart attack. They survive the heart attack, but they may have some difficulties afterwards with their heart function, and they will need support as they go through their illness trajectory. So this is what we say when we say that palliative care is disease agnostic. And because it's open to many diseases, I want to encourage us as a public to be more comfortable with seeking referrals and accepting referrals when palliative care is made for people with end-stage diseases. Now, what I want to do in just a moment is share with you what is oftentimes referred to as an integrative palliative care model. And some people call this the bow tie model, illustrating how we would like to see palliative care provided. And if you notice on the left side of this illustration, you see the words cure and control. And so when the person is newly diagnosed with a life-threatening illness, a life-limiting illness, they're going to go and have therapies. Maybe if it's cancer, may have immunotherapies, chemotherapy, etc., radiation therapy. And so we're going to try to do our best to do cure and do management and do control. But if you notice at the end, in that sort of overlapping pink, palliative care is there, but it's just at the beginning and it may not be that much involved. And in the early stages of palliative care involvement, this is where we can start encouraging people to think about advanced care planning, to think about what would their wishes be, what would their values be. And one of the very important roles of the palliative care team is just letting people know that they're not alone. There's somebody there with them on the journey. And this can be very reassuring. But as you notice with that particular illustration again, that as the illness trajectory moves forward and maybe they're moving towards the latter part of their life, palliative care becomes more and more involved, where the cure and control becomes less and less involved. And of course, you may see like admissions to a palliative care unit or admissions to a hospice. One of the things I don't think we do as well as we should is the area of bereavement, but hopefully in the future, that'll be an area that we can work on. So this is what we would think of as the new model of integrated palliative care. One other slide that I wanted to share with you, and those of you who have been with me in presentations before know that I like to discuss or share with you some ideas around what I call the paradox of palliative care. And I'd like to share just some information about how with early palliative care and early involvement, that people not only have the experience of better quality of life across those whole domains of total pain, but they may also have longer survival. I mean, there's a famous New England Journal of Medicine article, which gives us some empirical evidence about, those with lung cancer, how with early palliative care, they survive longer. And certainly in my own experience, I knew one person who, more than one, several, who we thought was going to die in August, but with the palliative care referral and just a simple assessment, holistic assessment, and some use of steroids, that person was able to breathe better. And they left the hospital and they went home, and they were home until January. And they were not expected to survive until January. And I actually had the conversation about funeral arrangements back in August. And it was wonderful to see this person survive because of a palliative care involvement in referral. And I will tell you, the spouse of this particular patient, after when they came back in January, she was effusive in her gratitude to the palliative care doctor. She was also so grateful for the role that the chaplains played in that sort of addressing total pain for her husband, and also for the quality of care that they got in the hospital and in the community. I also just kind of wanted to share with you something too, which I would think of as a simple logic. If pain is under control, and let's just say if total pain is under control, the person would want to live longer. And it makes kind of sense, right? If you're in a lot of pain, you're going to be saying, oh God, I just want to die. Just take me. I can't deal with this anymore. And that can be angst. It can be physical pain. It can be other things. However, if we can address pain, address psychological factors, social factors, the person may say, you know what, I want to live. There's a wedding coming up in a few months from now. There's a graduation coming up. I want to live. I want to be present for that. So there's a simple logic to it, but there can be other contributors like the assisted living that help us. This next slide, I just wanted to share with you about the ideals of palliative care. Palliative care, the goal is to help you live as well as possible for as long as possible. It's the right care in the right place with the right time, the right team, and the right communication. And the right team is, I mentioned to you, I mean, in an ideal situation, you would have a number of practitioners and resources available to you, but I know this is not always the case because I know in rural areas, you may not have access to some professionals that could be helpful. We were having a discussion about people with difficulty breathing and the fantastic role that respiratory therapists can provide. However, respiratory therapists in the community are few and far between, but they can be extremely helpful. And of course, right communication, we need to make sure that our information moves from one point to another point. So each person involved in care can know what's current and know what the findings are in order to make the best recommendations for treatment. Now I'm almost coming to a conclusion, but I wanted to share with you just some of what I see as the desired outcomes in palliative care. One is certainly an earlier referral to palliative care. I share with you stories about the paradox of palliative care. And when I do community presentations, we talk about this a little bit more, because I want people to be less afraid of palliative care. This is the second point here, diminish fears about palliative care, because there's a fair number of people in the community who when they hear palliative care, are frightened hearing that. And so we want to try to diminish that. And I think if we have an opportunity to get into faith and cultural groups, community organizations, and speak about palliative care before a crisis situation, hopefully we can encourage people to be more comfortable with accepting and or a referral for palliative care. Another desired outcome of palliative care is that we want to have care in the setting the person wants. I mean, if they want to be at home, that's great. Many people are uncomfortable with somebody dying at home, so they may want to have a hospice. I wish in Ontario we had more hospices so that this would be an option, because they are smaller and more home-like. Certainly we have some good palliative care units, but I think we need more in that sense. And sometimes people may even need to go to hospital if pain and symptoms are not being well managed. But hopefully we can avoid hospital admissions, especially during this time of COVID. As we said earlier, one of the desired outcomes is that we can ensure a better quality of life from the physical, social, psychological, and spiritual point of view. And don't wait to the end of life for a palliative care referral. Too often we say, oh, somebody's going to be dying in the next short while, and then that's when they make the referral. And I think then it's perhaps it is not the best time. We need to try to move palliative care to an earlier point of in the illness trajectory. I mean, and one of the ideal situations I saw was an oncologist sitting with a palliative care doctor, and they were going to be sort of aggressive in the therapies they were recommending, but made the person aware, here's the palliative care doctor, so that when time comes, that resource is available to them. The other point that I wanted to make too, that in my desire and my hope, is that with earlier engagement of palliative care and with its holistic approach for caring for a person, we hope that we can reduce some of the referrals for euthanasia, for medical assistance in dying. And I think that to me is a goal that I hope we can achieve. But as others have said several times today and yesterday, palliative care is not as robust in our provinces and our country as we certainly would wish it to be. And as I come to wrapping up, I wanted to just share these few words from Ramdas. And, you know, I like to think of as health care providers, that we are accompanying people on their journey of care. And I loved what he said and wrote here. We're all just walking each other home. I just love the connotation of that, of walking down this path with people and walking each other home, assisting them. I will leave this screen for another point in time. My slides have some resources. Pallium Canada has some terrific work that they've done. Canadian Hospice Palliative Care has some terrific work, and certainly the Serious Illness Conversation Guide and is a very good resource and tool. And I will say thank you for allowing me these few minutes to share some thoughts with you about the philosophy and practice of palliative care from my perspective. Thank you very much.
We will begin our question period. How we're going to do questions tonight is each of the questions will be specifically addressed to one of tonight's presenters, but open to the other presenters to join in afterwards also. So the first question is going to go to Dr. Sephora Tang. And the question is, if MAID becomes legal for reasons of mental illness, where would suicide prevention fit into healthcare? This is from the person who submitted the question. I'm a mental health worker, and I can't imagine how this would be handled. For example, when to help mentally ill patients' lives versus help them to die. Dr. Tang, what are your thoughts?
That is an excellent question, and the same question that I would like to ask the federal government as they are trying to come up with a law and legislation to manage this, because you're right. I see that this legislation is completely contrary to what we in mental health try to do, which is suicide prevention. And it really makes no sense to me that they're expecting us now as psychiatrists or mental health workers to facilitate suicides. So that is an excellent question. And I do not have an answer to that, which is the reason why I feel that this legislation is so dangerous.
If I may, I would just point out that the day after the House of Commons approved the C-7 on December 10, that the House also approved a motion to establish the 988 suicide prevention hotline. So here you have the response of our government or our society to that big questions of suicide prevention. All we do is just to provide a telephone number, and that will take care of everything. Am I right, Dr. Tang?
I actually did not hear that was what they were trying to do. That's news to me. But I will add that I think, again, this begs the question as to whether we would want psychiatrists to be involved in this whole process at all. If patients are coming to hospitals or seeking psychiatric care for their suicidal loved ones, you really want to be assured that the psychiatrist attending to your loved one's care is not going to be offering assisted suicide. So I think one of the safeguards that we could have for providing psychiatric care to our patients who are vulnerable is to not involve psychiatrists in that process at all.
Thank you both.
Except for perhaps, giving our professional opinion on the diagnosis and adequate supports and management.
Thank you both. Our next question is directed to Dr. Kotalik, and it is there anything that provinces can do to ensure monitoring and safeguards, since it is the provinces themselves who provide healthcare?
Yes, definitely. Provinces have a responsibility, at least. Federal government identified that the responsibility in kind of an offhand manner. But what happens is, seems to me that the gap between the federal and provincial government actually led to the fact that provincial and territorial government didn't seem to make any visible effort to take this task. Or maybe there are some sort of departments in most places or offices receiving these reports, But if they do, then they do not provide any report to the public, and the publication and release of those outcome of the monitoring is an important part of the whole affair. So we cannot have a transparency and accountability unless that analysis is already sent to the also sent to the public. So, but the problem, I think, is that we have 13 jurisdictions, and because there is no federal pattern how to do that analysis, actually, we probably very difficult to expect each of the jurisdiction develops their own program and that they will be compatible and fair and so on. Ontario chief coroner has went ahead and created a bit of a framework how to assess deficiencies in the reports and transgressions against the rules and so on. But that's probably, as far as I know, only remained as a draft, and I don't think has been officially implemented or distributed to other provinces. So there is a considerable amount of work which really provinces need to do, and they should do it in some kind of a collaboration.
Thank you very much. Our next question is for Bob Parke.
Here.
And the question is, thank you for speaking so eloquently about hope and resilience. When accompanying those with such painful suffering, such as late stages of cancer, how can we speak to the strong urge to end their suffering? In the moment, it can be extremely difficult to see how MAID would not be the best decision. What are your thoughts on assisting them at that time?
This is not an easy question in many ways, but that image that I had towards the end of my presentation was about walking people home. And I think one of the most important things to share is being present to people, listening to them, and then thinking about where might we be able to find other resources that might be affecting their thinking about how the quality of their living or the quality of their dying, and who might we involve in their care. But I think one of the primary and most important things is that we simply be present to them. And I think that can be a very big help, and let them know you are not alone. We're with you throughout this journey. It is no easy answer, but just being simply present, profoundly present.
Thank you, Bob. The next question goes to Dylan, and it is, do doctors who would refuse to recommend or administer MAID stand a chance in court in defending their conscience rights?
Very good question. And I would begin by answering that, and I won't pretend to be able to provide a fulsome or complete answer or legal analysis at this stage. But number one, I'd say I would have to read the final wording of the bill when it's passed. But I do understand that physicians are being required, and Dr. Sephora Tang can speak more about this. My understanding is that physicians are being required to be part of that process. Now, we do live in a system of devolved government, at least in principle. And by that, I mean that we have, as you know, we have local orders of government, right? So we do have municipalities and provinces, and of course, the federal government. And we also have sort of private public apparatuses, if you will. For example, the Ontario College of Physicians and Surgeons. And it's at that college level that you're going to find a lot, and that you are finding a lot of the struggling and tensions about whether physicians will be reprimanded for refusing to participate. I think that the freedom of conscience under Section 2 of the Charter will continue to be tested, and it has already been tested. But to date, I have only seen the protection of conscience used successfully to prevent a physician from being forced to actually participate in the procedures that they find objectionable. But I have not seen the courts extend the freedom of conscience to protecting physicians from referring. And again, that's where it's coming down to the colleges to determine whether they're going to take action against their members. It is uncharted territory, and I would urge physicians and nurses, nurse practitioners who find this and other procedures objectionable to take an active role in the governance of their local colleges.
Thank you very much. Good point. The next three questions, which are the final three questions, are for all the speakers tonight. So I'm going to put them out there, and hopefully a few of you will have some words for each of them. The first one, I was thinking, Dr. Tang, you might be able to start us off with a response, since you did the welcoming of Bill C-7 at the beginning of the lecture. And the question is, can you comment on the Senate's motivation to make the amendments? Who are the groups or individuals that are pushing for the changes in Bill C-7, and who benefits from these changes?
Well, I don't know the names of all of the groups that have been pushing for this, but certainly Dying with Dignity would come to mind as an organization that has advocated for people who want to have access to medical assistance in dying, euthanasia, or assisted suicide. The motivations, well, I honestly feel that the people who are advocating for assisted death or the legalization of assisted death are coming from a place of compassion. I think that compassion is misguided, and that they're not looking at the whole picture in terms of all of the lives of the vulnerable people who would be put at risk. And it's a very narrow view of the reality. But that's how we're here today. I don't know if it's true that there are going to be enormous cost savings as well. There was a parliamentary budget review, I think it was, that showed how many millions of dollars could be saved by removing the reasonably foreseeable death requirement in the bill. So I think that there are a lot of factors involved in why this piece of legislation in particular is being pushed forward so aggressively and so quickly. But I'll just leave it at that.
Dylan wants to say something, but I just wanted to add, it's not so much why it's being pushed forward, but one of my concerns is around the timing of it, because when we're going through COVID-19 now, and the difficulties and the challenges of COVID-19, for me, I'm just challenged by the timing of bringing this into fruition, and how do we learn about it, and so that, anyways, for me, it's the timing is a very, very important issue at this. There's a question and why.
If I may add something to that question, it's a very good question. Why, right? What's motivating all this? Certainly there are many factors, and historians and sociologists, like I said, can evaluate and give an appraisal of the history of what's going on. But I think that one thing I've observed, one thing I've hypothesized, yet to be confirmed by further analysis, is that as the old adage goes, the road to hell is paved with good intentions. I think that there are a lot of well-intentioned people at work in the Senate who are participating in what the then scholar Michael Ignatieff coined as the rights revolution. I think that a lot of these people imagine themselves to be warriors in the cause of rights. And Lionel Trilling wrote a book in 1955 called The Opposing Self. And in that book, he gave a history going back to the 18th century, of this notion of the what Charles Taylor would call the social imaginary, what people imagine themselves, at least in the upper crust, in the elite, what they imagine themselves to be up against. They imagine themselves since the 18th century to be up against rules and norms set out in society, which imprison them, which imprison the self, hence the opposing self, right? And so the heroic struggle of this self in an existential sense is to dismantle the norms and the structures that are preventing the expression of my freedom. And I think that the rules against assisted suicide and assisted dying are another new frontier, if you will, land to be vanquished in the cause of freedom and the cause of a radical freedom, understood as a Cartesian self separated from tradition, norms, rules, families, values, time and history and place, all these elements that contribute to the richness of a human being. These things don't exist for this Cartesian self seeking autonomy and control. What we need to do is remove those things, their barriers to this existential freedom, a very radical freedom. I think that's part of what's going on here.
This is excellent, excellent explanation. That's much better than anything I have read so far about this problem. But I guess in my simple way, as I see it, is we have an extreme individualism in our society, which makes each of us fully responsible for our actions and for our well-being and for our decision making. And so the dependency on others became virtually obscene. Actually, there is one intensive care specialist called his situation of one of his patients obscene because this patient needed so much care and there was no expectations of recovery. So we do not accept dependency. We want to avoid it. And then now we have an increasing evidence that the care which people can receive in the old age or with disability would be very inadequate. So many people do not have the families or someone looking to look after them will be dependent on institution. And now we have seen demonstrated in our pandemic now how institutions looking for disabled and elderly people are struggling to provide a very basic care. So I think I would think that psychological and social factors all contribute to that change in the perception.
Thank you to all four of you for really coming together to reply to that question. That was wonderful. We have 2 questions left tonight. And as we've said before, this is a really hard topic to face one night, let alone 2 nights in a row with all of these presentations. So we want to try to end with 2 questions of action and something and hope, something that we can take away from this presentation and really feel enabled to try to improve the situation. So the first one is once again for all 4 of you, and it is, how do we get governments to provide proper funding for equitable healthcare? COVID has exposed a serious lack of commitment to the elderly and vulnerable, such that it would appear people are not valued and society is unaware or lackluster in their demand for this to be resolved. What are your thoughts?
Wow, that's a great question. We've been doing a lot of thinking in my neck of the woods about equity and about working with racialized communities, working with people with disabilities. And I remember the disability community after SARS, and we were doing a review of what worked and didn't work. And the disability community member said, if you're not at the table, you're on the menu. And so one of the things that's important to us when we're doing work around policies and to address many of these challenges because I want to look around the table and see who's not there, who should be present. And I'm very conscious of some of the community health organizations which serve marginalized and racialized communities, and try our best to get them involved in this kind of policy making and decision making, and hearing their voices. Because I think, what did we hear last night about who was asking for this? It was the 4 W's: white, wealthy, and I can't remember the 2 other W's, but one has to do with sort of privileged. But we're not hearing the voices of those who are marginalized, and we need them present.
Those 4 W's was white, worried, well, and wealthy.
Thank you.
I guess I'll go next. So just speaking from the perspective of a healthcare professional, healthcare is legislated provincially. So I think there's a lot that can be done by speaking to our provincial members of parliament who will be deciding in their their provincial budgets where to spend their healthcare dollars. And one of the things that I had mentioned in my talk is that access to psychotherapy, for example, is very difficult to afford for many of my patients. I know that in Ontario, the government has actually done a really good job at implementing some short-term psychotherapy, cognitive behavioral therapies that a lot of my patients are benefiting. So I think that's a really great start. But that's just the tip of the iceberg. And if we can recognize the value that psychotherapy treatments have for patients who are struggling with emotional distress, I think we can go a long way in helping patients to find reasons to continue living again. But that support is just not there. And then the other issue that I had raised was the lack of affordable medications for a lot of patients who need it. So trying to put an infrastructure in place to be able to support individuals who cannot afford that would be very welcome.
I would, I think those 2 answers are terrific. And I would add another dimension to it as well. I'd say think local. I'm in the habit, the bad habit, of looking at the federal order of government and the provincial order of government and thinking, my gosh, what can I do? It's so troubling, and it really is. But lately, I've been inspired to get in the habit of thinking, what can I do on my street and in my parish and in my community, in my family? Because inevitably, we're the constituent pieces of the puzzle, right? And so if we are collectively coming together, I imagine in my mind's eye, the penguins in the far, the depths of the Antarctica. I think of them huddling together against the cold, right? That's the image I have in my mind as an example of what we have to do to protect our loved ones, and then grow from there to be a kind of light. Because I don't think people are joyfully, unless I've been misinformed, I don't think people are going joyfully into the hospital room to have the assisted dying procedure. There's a lot of suffering there. What's the alternative that we can provide, starting with us, to provide a joyful alternative, right? There is a contest of ideas happening here. So that's where my mind is.
Thank you very much. Dr. Kotalik, were you about to speak also?
If I may add
of course.
something to the very, very good comment already. I see that at the local level, there are a couple of things we could be doing. One is that we really need to be concerned about our families and our neighbors, the people who may be in distress, who may be not receiving services support as they would need. And so we really need to be very much aware of that, and perhaps we need to supplement what's the official network by more volunteer and personal involvement, all of us, in fact, to support people who might be close to the end of life, or those who are desperate in life. So I think that's kind of an individual action. Parishes could do it, communities could do it. And the other thing is, I think maybe we need to engage in investigating what's going on in our own communities about maid delivery. This program has been running essentially in a very secretive way. I guess people don't like to reveal that. They don't want to say their family member participating. Very few the people actually publicly declare that. As a result, the hospitals don't seem to include this in their annual report, and there is no reporting on the medical staff meetings and so on. So I think we should have some kind of a better local taking some local responsibility for the people who are moving toward the end of life, or who are moving toward applying for MAID. And again, and see if our community is doing enough in terms of the assessment and the support of these people.
Thank you so much for all four of you coming together to answer that. And as we see, we're getting towards 9 o'clock now. I think that joint answer by the four of you was really inspiring. And I think that I'm actually going to leave it with that question. It was a hopeful end to the lecture. So on that note, I'd like to thank all of you attendees for joining us tonight, and a special thanks to our four remarkable speakers who shared their ideas, experiences, and inspired us. It was truly an honor to have you with us. Just a reminder to everyone that last night's lecture is already available on our website, and tonight's lecture will be available on the website tomorrow. Everyone will receive an email to alert you as to when it's available. And please share this lecture and these presentations widely, especially with your MPs at this crucial time. And on that, thank you so much to everyone who was here tonight, and good evening.
Thank you.
Thank you. Pleasure being with you.
Thank you very much. Bye for now.